Hi, I'm Phillip Gu, and I'm the current IBD fellow at Sinai in Los Angeles, California. I'd like to thank Dr. Ali and the IBD Club for inviting me to present our recent work that was just published in the Inflammatory Bowel Diseases Journal, looking at visceral fat and how it can inform odds of treatment response and risk of surgery in patients with IBD starting a new anti-TNF therapy. I'd also like to give a special thanks to Dr. Gil Melman for mentoring me for this presentation. So as many of you may know, obesity has been described as a risk factor for suboptimal biologic response, especially with the anti-TNF class. Proposed mechanisms include increased proteolysis or the anti-TNF sink phenomenon, whereby increased levels of adipose-secreted TNF will sequester the anti-TNF drug. However, interestingly, clinical studies have only variably shown that obesity is associated with inferior biologic response. And this discrepancy potentially reflects the shortcomings of using BMI to capture adiposity. In the cardiometabolic literature, they've shown that actually visceral fat is a much more accurate marker. In IBD, visceral fat is highly relevant because it contributes to systemic inflammation through the production of pro-inflammatory cytokines. And there's a small body of literature that has shown that increased visceral fat is associated with more aggressive IBD, especially with Crohn's disease. So based on this data, it kind of raises the question, does visceral fat modify biologic response? So in this study, we sought to answer this gap in knowledge. We also wanted to understand if different visceral fat metrics have different prognostic roles when it comes to treatment outcomes. So to answer this question, we performed a retrospective study on IBD patients seen at 2 medical centers. Using available CT scans performed within 6 months of starting a new biologic agent, a new anti-TNF, we were able to quantify visceral fat and subcutaneous fat volumes for each patient. We then performed 2 separate analyses by stratifying patients by their absolute visceral fat volume and their visceral fat index, which is the ratio of visceral fat to subcutaneous fat. Our primary outcome was TNF response, and secondary outcome was surgery. We also performed a post-hoc analysis on drug concentration levels to see if this may explain our findings. We were able to include over 170 subjects and found absolute visceral fat volume was associated with TNF response in a non-dose response manner, especially at 12 months after starting their new biologic. We also found that patients with high VFI or visceral fat index were profoundly more likely to undergo surgery within 6 months after starting their new anti-TNF agent. Finally, we found that visceral fat volume was inversely correlated with infliximab trough levels, but not adalimumab. We also didn't find a correlation between BMI and any anti-TNF trough levels. So in conclusion, in this study, we found that quantifying visceral fat potentially has a prognostic role for treatment outcomes. Particularly, visceral fat index may identify patients with IBD at high risk for medically refractory disease and require surgery in the short-term future. Strengths of this study include a multi-site study in using CT volume metrics rather than calculating visceral fat area from a single CT slice. This has the advantage of being able to account for variations in fat distribution. Important weaknesses include retrospective study design and the potential for selection bias because we included patients undergoing CT scans for clinical indications. While future studies are definitely needed, visceral fat may be a potentially informative and cost-effective prognostic marker, especially when you consider diagnostic imaging that is routinely performed in IBD. Again, I'd like to thank Dr. Ali and the IBD Club, and I look forward to your questions.